Good afternoon, everybody, and welcome to NARA's presentation of leaky pipes and analysis of the clinical pathway for better outcomes for increased continence across the lifespan. This is our third and final webinar in the series. Today, we're going to be talking about applying everything that was discussed in parts 1 and 2. If you weren't able to join us for parts 1 and 2, you can find the handout and the recording on the NARA website. If you go to www.naranet.org and then click on education and then webinars, you'll see this posted, and then there's a link to the recordings from the previous two webinars. So I am going to introduce our speakers and do a little bit of housekeeping, and then I will kick it over to our speakers to dive into the application of everything that they shared with us previously. So our speakers today are Rachel Percoco. She has been a physical therapist for 20 years and a pelvic floor specialist for 19 years. Her current role is Director of Outpatient Services for Preferred Therapy Solutions. Beth Huller, our second speaker, has been a physical therapist for 25 years and a pelvic floor specialist for 7. Her current role is Regional Manager of Sales and Business Development for ACP. And finally, Rita Cole has been a speech language pathologist by background and has 30 plus years in direct care, patient care, clinical programming, and compliance management. Her current role is Director of Clinical Services with Net Health. All of our attendees are on mute. We will have a handout available with these slides after the presentation has been completed. We are recording the webinar today, and it will be available to you in about 2 days. So it should be available on the website on Monday. And for our NARA members, you'll be able to find this quickly at the NARA portal under webinars. If you have technical questions, please use the chat button in the attendee toolbar, which should be located at the bottom of your screen. If you have questions for our speakers, we ask you to use the Q&A button that is also located on the attendee control panel. And as I mentioned, we are recording this. It will be available in the member portal, but you will also be able to find it along with the recordings from webinar 1 and 2 on the NARA website under resources and the quick links page. All right, I will now turn it over to our wonderful speakers.
Thank you, Christy. My name is Beth Huller, and I'm going to start us off today. I'm starting with some slides that we had hoped to fit in on the last one, but because of the little bit of technical snafu, we're going to start with that today, and then we'll move in onto Rachel and Rita. So our objectives are to continue to identify treatment options. We're going to talk about application and treatment strategies, implementing strategies to defend medical necessity and safeguard reimbursement, and then identify the clinical value trajectory for public health services and programming. Next slide. So I'm going to start us off today with NMES as a treatment. From our last session, we talked about some treatments looking at the exercise for postural muscles as well as with your pelvic floor muscles. Neuromuscular e-stim has a lot of evidence to support it for treating urinary incontinence. This just goes through some of the most current research and some of the bigger research that's used by pelvic health therapists. But over 30% of women with stress urinary incontinence cannot voluntarily contract the pelvic floor muscles. And they found that neuromuscular e-stim is a great way to not only help get a full contraction, but also to help patients identify the muscles. In 2013, there was a systemic review of 33 random clinical trials, and it concluded that the tibial nerve, intravaginal, as well as sacral electrical stimulation show effectiveness in treating urge and refractory urinary incontinence. The first one that we talked about was stress. So now moving on to urge. I think the big thing to take from here is looking at the different types of urinary incontinence we have, and then knowing we have multiple different types of neuromuscular e-stim, so we're appropriately addressing them. Next slide. We talked a lot in the first session and the second session about posture. So, if we don't have proper posture, we are not going to be able to get a proper pelvic floor muscle contraction. So, no matter how much E-stim you use on the pelvic floor muscles, if we don't first correct the posture, we are still not going to get the strongest contraction we can get of the pelvic floor muscles. So, we do also have to talk about neuromuscular E-stim for posture control. This goes through some of the evidence that supports it, not only looking at posture for thoracic kyphosis, looking at the lumbar as well. One of the things that I'd like you to really take a look at here is just that electrical E-stim promotes neurophysiological changes, and it appears that stimulus adaptation of specific circuits can strengthen the brain's ability to distinguish between and respond to such stimuli over time. So, when we're looking at the treatment of neuromuscular E-stim and with our patients, getting patients to be able to maintain a correct posture is really a big goal when we're looking at urinary incontinence. If we improve their posture, we improve their ability to contract their pelvic floor muscles, we're going to have greater success long term. Next slide. So, our options when we're looking at neuromuscular E-stim are NeuroRead. This type of E-stim really focuses on that last one that I pointed out, how our brain is controlling muscles. So, we know there's a certain synergistic ability and coordination of our muscles when they're contracting. It's not just the size of the muscle. When we strengthen muscles, that first 6 weeks of strengthening is neurological gains. So we can increase strength, but it's all devoted to neurological reeducation, mainly looking at coordination. A patterned E-stim is an example of neuromuscular E-stim and can be used for posture. And you can also use it to impact your pelvic floor muscles and their ability to coordinate with the bladder in terms of when things are contracting and when things are relaxing. Muscle Rehab is a second intervention type. Last slide. Muscle Rehab is an E-stim that focuses on muscle hypertrophy. So once we have that movement down and we have the coordination corrected and as close to perfect as possible, our next goal is really to look at let's make that muscle larger. So we know a larger muscle is going to also impact strength. This is the next phase of strengthening that starts to occur about 6 weeks in an exercise program. These types of stims are your MFAC, which we typically refer to as Russian stim. It's a medium frequency alternating current. Or you can use a low volt pulse current if it's for smaller muscles. And sometimes, specifically when we're looking at postural muscles or we're looking at pelvic floor muscles, that might be something that's more comfortable. And then the last is a functional rehab. And functional rehab E-stim focuses on improving movement patterns or a muscle contraction during a functional activity. So there's patterned E-stim. You can also do this with low volt pulse current or MFAC. Very often, we're going to see a switch being used with this. You can do this if you have somebody, if we're talking about urinary incontinence, we want a pelvic floor muscle contraction prior to that increase of intra-abdominal pressure when they do a sit to stand. You can do a pelvic floor muscle contraction with functional rehab during that functional exercise. Next slide. So you can understand kind of this is a brief overview of neuromuscular E-stim. There are so many different options when we're looking at the treatment specific to urinary incontinence. Those E-stims we can do internally with a probe. We can do pad placement where we're crisscrossing the pelvic floor. We can do pad placement over the neurological levels. We can do pad placement on the sacral nerves. We can do posterior tibular tib stim, which is doing an internal stim, all different opportunities. So we really can't go into that in the length of this training. But what I'd like you to really take from this is a common stim that we all use for posture. This is very appropriate and a great adjunct to any treatment plan for somebody that's suffering with urinary incontinence, working on the postural muscles. So this is an example looking at lumbar where we're on the abdominals and the low back, and you can use any of the waveform types listed there as a kind of pre-treatment to improve your pelvic floor muscle contraction. I'm going to pass it off to Rachel for biofeedback.
Okay, great. Thank you. So biofeedback, the the definition of biofeedback is using a technique to gain a greater awareness of one's own body. So why biofeedback is so unbelievably important for the pelvic floor, so incontinence or any pelvic floor disorder, is because like we discussed on day one, you cannot see the muscles. And it makes it really hard to understand what these muscles are supposed to be doing if you cannot see them. So biofeedback is a huge tool with this population. And there's multiple ways you can do it. One of my favorites is simply using a mirror. So even though the muscles are internal, when we look externally and ask somebody to do a pelvic floor contraction and relaxation, we do see changes, subtle changes, but you can teach your patient what to look for and it can help them to connect like I'm doing the right thing. I'm doing the right movement. Utilizing a blood pressure cuff. So if you have somebody on their back with their knees bent, we've talked about the correlation between the pelvic floor and the abdominals. So if you put a blood pressure cuff unwrapped under somebody's lower spine and you pump it up just to the first little notch. If you cue somebody to squeeze their pelvic floor, draw their belly in, that's going to create that little bit of pelvic mobility into a posterior pelvic tilt. And the person can see on the gauge that the pressure is going to go up. So again, it's just another technique that's visual that can help somebody connect to this part of their body. Now, this is for the pelvic floor trained clinician using EMG. It is an extremely powerful tool for this population. So we either do this internally or externally. Externally, we would use the electrodes around the perineum and around the anus. And why would we use external? Pediatric population, we would always do external. If somebody has severe pain and can't tolerate internal, or if sometimes when women are pregnant and we don't want to do any internal work, external is a great option. For internal, we would use either a vaginal or a rectal probe. And what happens is on a screen, and there's a lot of variations of how this can look. There's some very cool programs out there, but basically, you're looking at like a line that when you squeeze your pelvic floor, you're going to see the line go up. And then when you relax your pelvic floor, you're going to see the line go down. So I many times, when I've done biofeedback with somebody, they're like, that is it. That is what you are asking me to do, because they can actually see visually when they're doing a contraction. EMG biofeedback is also very helpful for overactive muscles, because if they're starting at a shortened position and we say relax those muscles, that's really hard to do if you're not sure what you're asking your body to do. But if you're looking at a screen and you're seeing yourself start at a level 10, you do some deep breathing, some relaxation, you see that line start to go down. It teaches the brain what the sensation feels like. I just wanted to mention RUSI, which is real-time ultrasound. If you have access to this in any of your clinics, my first clinic that I worked at did have this. It is an incredible tool for the pelvic floor population. So it's an ultrasound very similar to when we're looking at a baby. What you can see with real-time ultrasound is you can see the bladder, you can see the pelvic floor muscles contracting, and one of the most fascinating things I learned through RUSI was we talk about the transversus abdominis, which is that corset, the deepest abdominal muscle. And if I have my hand palpating externally with the RUSI and I cue somebody to gently draw their belly button in, I can visually see on the ultrasound those muscles kick in before I can feel it under my fingers. It's that subtle of a movement. So if you have access to RUSI, it's pretty incredible. And then bladder training. This is a huge part of what we do with incontinence. So this is an example of a bladder diary. What a bladder diary is going to tell us is what is going into the system and what is going out of the system. So this example is going to look at the time of day that somebody voids and how much, small amount, medium, large. What are they drinking and how much are they drinking? What are they eating? If they leaked or the time they leaked and what happened when they leaked. Was it related to an urge? Was it related to a sneeze? It gives us a tremendous amount of information. Excuse me. With stress incontinence is helpful, but bladder retraining is really key in urge incontinence. So if you remember from day one, the bladder has two jobs. Its jobs are to store urine and release urine. So I'll just give a very general expectation of somebody with urge incontinence, what their bladder diary would look like. Likely they are voiding very frequently. So, say they're voiding every 45 minutes. Bladder should be able to hold urine for 3 to 5 hours. Urge incontinence and urgency and frequency, we're going to see somebody who's going to the bathroom all the time. So, they're voiding every 45 minutes. Maybe they're taking in a good amount of bladder irritants. They're not drinking much water and they're leaking with urge. So, what we do with this information is we can say, okay, you're urinating every 45 minutes. We're going to train your bladder to store urine. So we're going to bump it up to an hour. We're not going to jump to 2 hours because that's not reasonable. This takes time and it's actually quite hard work. So we're going to say, okay, you're going to get an urge at 45 minutes because you've now taught your bladder that it gets to go to the bathroom every 45 minutes. We're going to bump it. You're going to delay until an hour, but we have to give you tools. So there's certain urge suppression techniques. We talked about quick flicks. Remember, when the pelvic floor muscles contract, the bladder relaxes. So if you have an urge, you can do a series of quick flicks, squeeze, relax, and that is going to quiet that bladder down. If you think about when a child has to pee, what do? So they cross their legs and they will hold themselves. And there's two reasons that they do that, not knowing. One is external stimulation is an urge suppression technique. The squeezing the legs together is actually eliciting an adduction contraction, which is a synergistic muscle to the pelvic floor. So we know that you could squeeze your knees together, and that's going to help you to get a pelvic floor muscle contraction, and that is going to suppress the urge. The biggest one I use with patients, and they laugh in the beginning, but you have to talk to your bladder. Like you have to tell your bladder, it's your job. Like you got to wait. We're waiting 15 more minutes. And it sounds silly, but it works because it's not that it's in somebody's head that this is happening, but it's very neurologically based. The impulse is, remember, it's against those stretch receptors. But if we teach the stretch receptors that when the bladder is barely full, it sends an urge, and then you go and empty your bladder, the bladder learns that. One thing I always tell people is it's going to get worse before it gets better. So you want to do bladder training when you're home, when you have access to a shower, when you have a pad on, because it inevitably is you're going to leak more while you're training your bladder to do its jobs. So just to review, we're going to look at stress incontinence and urge incontinence. So stress incontinence, loss of urine with increased abdominal pressure, sneezing, laughing, coughing, jumping. This is a situation of underactive pelvic floor muscles. So we're going to do pelvic floor muscle and core strengthening. We're going to work on endurance, activity modification. Say you have somebody that just had a baby and the abdominals have not recovered, the pelvic floor muscles have not recovered. And every time they go to sit up, they have a leaking episode. We may teach them to log roll while we're doing their rehab. And we want to treat to function. So the story I like to tell to explain this, I had a patient that was a professional horn player, and every time she played her horn, she leaked. So I had her bring her mouthpiece in, her horn mouthpiece in. And as we progressed her exercise program, I had her blowing into her horn piece because that's when she's leaking. So we have to train the muscles to do their job, the job that we're asking them to do. And then bladder training, just knowing what's going in and out is important. For urge incontinence, on the other hand, this is typically a situation of overactive muscles. So we have to do down training. The muscles that are synergistic, the glutes, the abs, the adductors, when we're strengthening, we're also going to strengthen all those muscles. When we're down training, we have to make sure we have full range of motion and we don't have pain in those synergistic muscles. We do a lot of manual techniques, both on the pelvic floor muscles directly. We do, trigger point release. There's a lot of different types of manual skills, but we also do manual techniques around the abdomen, the back, the pelvis, the hips, the inner thighs, because the system works together. Like I said, bladder retraining is huge with urgent continence and collaboration with the healthcare team. So anytime we're treating somebody with incontinence, yes, we're probably working with a urologist, urogynecologist, gastroenterologist. We're going to be working with the healthcare team, but with urgent continence in particular, often there is a medication on board too. So there's typically a pretty close collaboration with the whole healthcare team. So we are going to do a case study. Now, this is a real person in my life. We have changed his information and his name, but this is a real person. So meet Marco. He is a 78-year-old man, lives in independent living with his wife. Past medical history that is pertinent to this scenario. He has BPH, which is benign prostate hypertrophy, type 2 diabetes, hypertension, and coronary artery disease. His symptoms are urgency, frequency, and mixed incontinence. So, mixed incontinence is when you leak with urge and stress. We do typically see that more with females just because of their anatomy, but it certainly can happen with men too. And of note, he has a new diagnosis of dementia. When we do an objective evaluation, we find he has a posterior pelvic tilt, a kyphotic process, and overactive pelvic floor muscles. Stepping back before we go into how we're going to treat him, when we have mixed incontinence, and I know we talked about this in the beginning, those muscles are overactive, but they're also weak. We can't strengthen muscles until we can get full range of motion. So the focus is going to be on addressing the overactivity of those muscles before we can even start to think about strengthening. So, what are we going to do with Marco? So, at this point, finding a pelvic floor therapist is a great idea because much of what happens um, with the treatment, it does involve a level of cognition where new information can be learned and processed. Like I said, I have evaluated hundreds of people that are very connected to their bodies and they still don't know what their pelvic floor is. So there does have to be some element of cognition to be able to connect the pieces. Um, you can consider telehealth. Much of what we do in these treatments is education based. So telehealth is a really great option at this point. Um, Checking toilet positioning. Very basic, but we talked about the pelvic floor muscles have to relax for the bladder to empty. Um, a lot of men don't like to hear this, but one of the first recommendations, if I don't think somebody is fully emptying their bladder, is to recommend that he sit down on the toilet. And then providing written reminders, sit down and relax, drink water every hour. The reason I laugh is because the real person in my life said to me, "You're not going to believe this. I read on the internet this is a real thing. It's called urgent continence. I need to do this bladder diary." And I was like, "No, no, no. I'm the one. That was me. I told you to do that." So the lesson is, we know he has some earlier stage of dementia, but he has dementia. So written reminders is key. Literally putting a sign in the bathroom, sit down and relax. Yeah, this person in particular was not drinking any water. So I don't want him drinking a ton of water, but like a Dixie cup or a shot glass of water every hour. But there was a sign up in the kitchen to say that. Okay, so now Marco has had some things happen. It's 2 years later. Marco has now advanced to a stage 6 dementia. He's now residing in a skilled nursing facility. He's ambulatory, but he is having recurrent UTIs and he's having repeated falls. Again, if you cannot empty your bladder, that puts you at very high risk for UTIs. So now what do we do? So we can definitely still help Marco, but it's a completely different strategy. Um, Looking at a toileting schedule. So any of us that have worked in skilled nursing facilities know that we have staffing shortages. It is not realistic to expect the nursing staff to put them on a toilet schedule. If that's possible, that is helpful. But I put that there because in a perfect world, yes, that would be wonderful. But in the real world, it's not super reasonable. Toilet positioning, on the other hand, if we have to raise that toilet seat, or the toilet seat is too high and we need to put something to support the legs, those are some very easy things that we can do that can really help somebody like this. Bladder trigger. So I want you to think about the little old lady who's lives in the sniff, and she's in her, she's in her wheelchair and she's saying, I have to pee, I have to pee, I have to pee, I have to pee. Um, if the staff is only giving her orange juice and coffee, it's just going to make her bladder so irritated. So we can definitely do some training with the staff on how to make this a better scenario. Are we going to completely get rid of the incontinence? Probably not. But certainly, if we can reduce those bladder irritants, within reason, we're not going to take away the coffee completely, but it knowing that if somebody's only taking a bladder irritants, they are 100% going to have an irritated bladder. And then let's go back to what we do as therapists. So PT, let's be looking at our strength and range of motion. How's balance, coordination, transfers, ability to walk to the bathroom. For OT, do they have the dexterity to take their clothes on and off? Can they manage their clothing? Can they do toilet transfers? How is their hygiene? And then for speech, what are some compensatory cognitive strategies we can put in place to help Marco? And again, engaging, educating, and spreading awareness. That goes with the residents, the staff, their family members, the community. If you put some signs up that say top 5 bladder irritants, or sit down when you're in the bathroom, just little basic cues, it gets the conversation going. And honestly, it helps all of us. I'm going to pass it back to Beth.
Thank you. So there's a lot that, as Rachel showed, there's a lot that's involved when we're treating urinary incontinence. It's not you're going straight into the pelvic floor muscles. There's a lot of education and a lot of other areas of the body that we have to look at. So when we're looking at our services and the billing of that, I'm just going to go through what those codes might be for Marco. So 97110, muscle contract and relax training, coordination, and endurance as well as coordination again. And I like that coordination's on there twice, because this is something that we really do need to make sure is in place when we're looking at urinary incontinence. So I'm glad we got it there twice. 97112, neuromuscular, READ, so dexterity, fine motor coordination. If somebody's having trouble getting their pants down when they have urge incontinence, that fine motor coordination could really inhibit their ability to maintain continence. 97535, toileting, personal hygiene, clothing management, the toileting programming that Rachel talked about, UI product management, UTI management, and prevention, and the medication would fall under here, medication management. Next slide. 97530 would be in here too. So bladder triggers, really doing that education for what they need to be taking in, making sure that their bladder isn't triggering them to have more incontinence, toileting position, functional balance, transfer, and then bladder habit assessment and training would all be billed under 97530. I talked about NMES, and we do have 2 billing codes that are potential when we're looking at a patient like Marco. G0283, which is supervised e-stim, and 97032, which is manual e-stim. The difference between the two of those is if you are in charge of turning the stim on and off. So if you're using a probe, we do manual e-stim. Most of our pad, if we're using electrodes, e-stim is going to be billed under G0283. So that example that I showed for lumbar. Next slide. And then the remainder of our codes, 97140 for manual techniques, and then biofeedback, which does have 3 different billing codes. And we have on here to check with your local coverage determination and practice, because it's not as straightforward as some of the other codes. Some of the LCDs will deny biofeedback and would prefer that it's billed under neuromuscular reeducation. So keep that in mind. Make sure you're always checking with your corporation and how you guys want to proceed per your LCD. So I'm going to pass this on to Rita to finish it up.
Thank you, Beth. And I have to say that you and Rachel are both correct in saying there is a lot involved. And I think it brings us back to the fact that across our 3 webinars, we've identified the pelvic health and continence management clinical pathway for participants with the different conversations around evidence-based evaluation and treatment techniques, the protocols, the coverage guidelines, and the reminder that both your patient and your provider outcome achievements are largely dependent upon you ensuring that your documentation reflects your use of that clinical pathway one patient at a time. Use the right words and you will achieve the right results. Let's apply that concept to Marco's case study. So on the left-hand side of the slide there, you'll see the list of the 6 core documentation components that we addressed in our last webinar. These are the essence of medical necessity that must be reflected in your documentation from evaluation through discharge. They will reflect that you are facilitating your patient's functioning at that person's highest potential, as well as facilitate your reimbursement for services. On the right-hand side of the slide there, you see pieces of information that the PT received as part of Marco's referral. And so just a few things to highlight that Rachel mentioned about Marco captured with the referral. The diagnostic information was presented, although it's lacking details about the length of time or the management methods specific to the diagnosis. The referral was noted that Marco lives with his wife. However, it didn't provide any information about Marco's skills, his preferences, or his abilities. The new diagnosis of dementia stage 2 was presented, but that in and of itself can be misleading without knowing the staging tool that was used for that. The symptoms were a good starting point, although that didn't pinpoint how long Marco had been having the symptoms. It also didn't note if it was a new onset or an exacerbation or how the referral came about. All these details are important for identifying and supporting an outcome and must be documented. So you'll see here on the slide, current and prior medical history, the start of some example documentation. And we started with this because we want to make sure that you're ensuring your history is thorough and it's relevant. And that's for prior, for current, for complexities, and for social history. On the next few slides, I'm going to go through and pinpoint a couple different things because I want to make sure you see that the PT was incredibly successful at documenting relevant information. So on this slide, you see that the PT clarified this was a new onset. The PT noted how the symptoms came about and noted the medical management that was used thus far. Now, the benign prosthetic hyperplasia or hypertrophy that Rachel mentioned earlier may not be related to Marco's issues now. However, it's good to document because we know it does have an impact on urinary incontinence. And that's the same thing with diabetes. It's considered a significant risk factor for urinary incontinence, primarily due to the nerve damage that can be caused by high blood sugar levels, which can affect the bladder muscles. Contraindications to any possible treatment are also important to note. So you'll see that the PT mentioned pacemakers, stimulators, also noted cancer. That there was no diagnosis of cancer, sorry, just to clarify that. And so then on this current slide, you see that the PT was, again, very concisely documenting details to support the change in Marco's condition that established the need for PT. In our last webinar, we talked about the opportunity with pelvic health and continence management to easily show the value of therapy. Ensuring your documentation connects the feelings, emotions, and psychosocial impact that comes with physical issues and functional changes is super important in showing the value. So bravo to the PT for getting personal with Marco. The documentation clearly reflected that Marco was thriving before these new continence issues. He was an active life participant. He preserved relationships. He was connected with others. He was a loving husband who doesn't want to disrupt his wife. So now he's wanting to sleep in a recliner chair so as not to bother her. I also want to make mention that the PT described Marco's cognition and linked it to his health literacy, both very necessary to support outcomes. Next slide, please. Prior level of function is primary in supporting the long-term and short-term goals. It too must be thorough, but focused on relevant elements. On this slide, you will see some very crisply written examples that apply to Marco's case. The physical therapist documentation supported physical function, environmental factors, cognition, and bladder irritants. Note also that continence management products were noted as new for Marco. And then lastly, the PT documented his hand dominance, and that's key for success with any compensation or adaptation treatment interventions that would be part of the plan of treatment. Next, objectivity is a must in documentation. It's the essence to your ability to reflect change with the services that you're providing. Again, cheers to the physical therapist. On this slide, you will see strong examples of the objectivity included in Marco's physical therapy medical record from the start of service. It's a perfect reflection of the connection of the physical pelvic floor performance to the resulting incontinence function. And the PT pulled out the inclinometer that Beth had mentioned in one of our previous webinars. Also remember that Rachel mentioned Marco exhibited overactive pelvic floor muscles, so there's supportive documentation for that physical impairment as well. Now, similar to Marco's cases with many of your patients, there's likely a large variety of options you'd have to address function, and the PT narrowed it down pretty well for Marco. Next slide, please. Information on this slide here is just additional in terms of supporting a successful patient outcome. Again, objectivity is key to showing change in function. This is a beautiful way to tie what could be a concern for Marco and his wife, money and new costs related to the continence products that are now a new use. And that, of course, is the PT thinking about social determinants of health. In the absence of any information about the dementia staging tool, the physical therapist provided objective description of a few of the cognitive aspects that could definitely have had a result on Marco's success with treatment. New learning can impact direction of treatment, number of sessions approved, and your reimbursement. If you lined up 10 patients, PT plans of treatment and discharge summaries for persons with mixed incontinence like Marco, you'd likely see similarities across all of those. This is just a reminder from our last webinar that the choice of a more formal patient-reported outcome is a distinguishing factor in documentation. It emphasizes patient-centric care, and it provides an objective measure of the patient's perception of the impact of the issues. I want to point out here that on one of the earlier slides, it was reflected that the physical therapist did mention that Marco had concerns for tripping because he was trying to get to the bathroom quickly because of the urges. And the physical therapist also then presented the consideration for being able to measure outcome achievement by using a non-incontinence type of patient-reported outcome for the patient's case as well. So compiling those components with Marco's clinical presentation during the eval, the physical therapist had options for goals for underlying impairments, functional deficits, and quality of life. So let's take a few of those. And on the slide, you see here those that are related to underlying impairments. Beth addressed the impact that body posture could have on pelvic muscles in our last webinar. So the physical therapist determined that Marco's kyphotic position did play a part in his functional deficits. So there was a goal that was developed for that. The physical therapist documented Marco's intake history with bladder irritants and made the decision that he and his wife needed some education in lifestyle changes specific to that. So during the treatment episode included goals to measure those changes. And there's a few examples of different ways to document that. And then on our next slide, you see some example goals that are based on function. As we did see earlier, there were several different objective functional deficits that were defined during the assessment by the physical therapist. And given Marco's high cognitive function and health literacy, any one of those would be good goals to focus on specifically for function, not just as a starting point, but also as he progressed through treatment. And then lastly, the physical therapist captured several patient-centric quality of life issues that impacted Marco's social life, his personal relationships, his relationship with his wife, his involvement with his grandchildren, his on and off campus community activities as well. So any of those could have been utilized for documenting a specific goal related to quality of life. And that's throughout the course of his treatment as he progressed. All of that information together supports the use of several different treatment diagnoses to support the pelvic health programming service that was being provided. So you'll see on the slide a couple of different ones that were noted in the physical therapist documentation. Next slide, please. So a reminder, the right words to achieve the right results is applied throughout the treatment episode. I think as therapists, our session notes can be the most challenging for documentation out of all the documentation in terms of supporting medical necessity. To meet the medical necessity requirements noted in the coverage guidelines, documentation must reflect that your services can be safely and effectively performed only by a clinician for this patient and using acceptable practice for the patient's condition. That brings us to this list of things to avoid in clinical documentation. Really just a reminder, but I think if you think of it a different way, if you laid out your daily session notes and you reviewed them and you asked yourself, do these look pretty much the same? Do they look as though someone non-skilled could have been providing the service? Or do they appear to reflect progression, some modification, some training, movement towards your end goal? Thinking about the treatment approach for Marco that Rachel did review earlier. Next slide, please. To reflect skill, remember the hierarchy: physical assistance, guided assistance, supervised assistance. So on this slide, there are some examples there that incorporate those different concepts. Of course, any cueing, thinking about the cueing hierarchy, is definitely some content that would support therapy services. And then documenting the patient's response to the treatment, the patient's perceived level of difficulty with exercises or bladder irritant training or the diary is definitely something to include in documentation. And then next slide. I'm sure you're performing the service. Just a few examples as reminders to focus on the key words. Skilled clinicians are needed to establish an exercise program, to identify the components of a tracking log, to determine if modalities are needed, to make the decision as to when to progress the patient through a program, whether or not to use manual techniques to facilitate the system working together, to determine whether or not to start with ranging or strengthening, and when to progress the patient. Documenting response to a technique like biofeedback that Rachel described, teaching relaxation or the affirmation techniques that Rachel mentioned earlier, instructing and modeling with urge suppression techniques, the affectiveness on the patient's behavior, the carryover, the generalization. It needs to be documented to support that you as the skilled clinician is needed. Next slide, please. So specific to electrical stimulation, thinking about the coverage guidelines discussion that we had last webinar, this is just a reminder about different components that help make the service skill. It's not about whether or not you're turning it on or turning it off. It's really about your determination to use it or to not use it, the type, the waveform, identifying the correct location, and then adjusting that as needed for the patient, when to ramp up, when to ramp down, skin assessments, patient's response to it. those specific components that only you as a clinician can do. And just a reminder that LCD considerations can be a little bit different. So making sure that you're checking about whether or not pelvic muscle exercise is needed, the type and the amount prior to introducing the electrical stimulation. On the next slide, there's some examples really for your reflection related to session documentation. All of those reflect the need for a skilled clinician for E-stim treatment. It's not intended to be an all-inclusive list, of course. Might provide affirmation for some of you regarding your daily or your session documentation supporting E-stim, and for others it might be providing some new thoughts and ideas. Next slide, please. So Rachel did mention as part of Marco's case scenario that he did have a transition a couple years after IL of needing to be in a skilled nursing facility. And that was mostly because his cognition changed. He was having UTIs and he was having falls. So you see here on the left-hand side of the screen, his status at discharge. And then, of course, on the right-hand side, some information with your new referral. Now, we don't live in a perfect world, so we acknowledge the fact that there's going to be challenges in obtaining the status at discharge from his previous therapy, especially 2 years later. But continue to ask the family, ask the wife, see if there's information that gets included in the medical record, because all of that would help substantiate the significant change that he's had. Capture more recent social history from the family. Make sure that you are getting some of the information, the how, the reasons regarding the UTIs and the falls. And then, of course, describe the new cognitive communicative status. And as Rachel mentioned, speech pathology and occupational therapy, bringing them in for assistance as well. Next slide, please. So you'll be addressing similar concepts of physical impairments, functional deficits, and quality of life, and the 6 core components. The difference will be with this change in status, the need to focus on the cognition as part of your care plan. You're going to have greater emphasis on the need to include caregivers, and you'll likely have greater emphasis on helping the family and Marco's wife with decision making about appropriate timing for transition back to IL, and or whether or not assisted type of service may now be needed, or assisted type of level of care. Next slide, please. So let's want to take one extra step in wrapping up the discussion about Marco and the thought about outcome trajectory. So in our webinars, we've mentioned pathway and outcome trajectory, or path or journey, is focused on the continuum of care. Depending on the location of care, whether it's a freestanding clinic, a hospital, IL, SNF, etc., each provider is certified a little bit differently. So the broad health outcome, or the quality measure, which therapy is a part of, is going to vary. While we don't have time for a full deep dive into quality measures and the related reimbursement programs associated with those, the next couple of slides here really emphasize that ultimately interdisciplinary collaboration for the patient's overall health is really what's critical. So there's the merit-based incentive payment program, and there's quality measures related to incontinence that are wrapped up into those. Again, it doesn't necessarily mean that anybody addressing Medicare Part B as the payer, that you'd qualify and be able to use those. So you need to make sure that you're being aware and you really do your research about those. Same thing with the SNF quality reporting program. It does include process measures and quality measures, and there's a few of those there listed for you for reflection and research if in fact you're providing services in a skilled nursing facility. And then next slide, please. Also related to skilled nursing facility services, there's the MDS sections where therapy can contribute to the data that's listed there. Given that clinicians typically facilitate patients functioning at higher levels, it's important that SNFs combine therapy data with the nursing data and other provider data so that there's accurate reimbursement is really the result. It's about collaboration. With that in mind, I'm going to pass it back to Beth so that she can wrap up our pathway discussion with financial considerations.
Thank you, Rita. And to go off of Rita's of the benefit financially, operationally to the SNF, there's benefits to everybody. So there's no arguing that continence improvement treatments have an amazing clinical outcome for our patients. The goal was of these 3 webinars that everybody's walking away thinking, I, as a therapist, can treat urinary incontinence. I can help with continence improvement and really help my patients in ways that I didn't know before or that I haven't been doing before. When we look at it from the outside in, really taking into account all of the different treatments that Rachel talked about that are really outside of just pelvic floor muscle assessment and looking at the posture and how we can impact the pelvic floor, every clinician can have a positive impact. But I also want to say there's also a positive impact operationally and financially. So this is not an extensive list, but just enough to give us that idea. It's a clinical benefit and an operational benefit. And we need to look at that every time. So it's the cost to the patient or the facility. So think about briefs, pads, laundry, caregivers that are needed to assist. Um, medications that they're spending money on. If they're coming to you as an outpatient, that's a lot of extra out of pocket expense. And then revenue gain, if you are in a facility, billing codes for treatments or in a clinic, all of the treatments that we discussed in those CPT codes are billable. And then increase referrals. This is a great program to really start marketing. With the high percentage of people with urinary incontinence, we need to be on board and we need to be ready to treat patients when they walk through our doors for continence improvement. So thank you, everybody, for coming. And then this is just a list of additional resources, and they're available upon request.
Thank you so much, ladies. Really great information. I really liked the detail in that case study. Do we have any questions for our speakers? If you have questions, feel free to pop them into that Q&A box. Just as a reminder, we did are recording this webinar, and it will be available the same as parts 1 and 2 were available. They can be located on the naranet.org website under resources and then quick links, and you'll see the 2 webinars previous are there with the handout, and then we will add these slides along with the recording around Monday. Great job, ladies, and thank you so much for taking the time to put this presentation and the other 2 presentations together and give us this information to help with treating patients and making sure that they have the quality of life that they desire. So since we have no questions, I will go ahead and end the webinar and give everybody the gift of 7 minutes. So thank you, everybody, for attending today, and watch the website on Monday for the recording.